shock in the pediatric patient as we're going through. I am recording this. Julia had to be out today for an appointment, and so I told her I would, if the technology works with us, we'll see what happens here, okay? The majority of the childhood medical emergencies that you're going to run into are going to involve the respiratory system. That's just the way kids are. But there are other types of medical situations that can come about and other body systems that can be involved as well. So when we're looking, particularly in the pediatric patient, we're looking at cardiogenic versus non-cardiogenic type of shock. And basically what we're talking about here, Tariq, is when we're talking about non-cardiogenic shock, we're talking about shock that results from any other reason than heart failure resulting in inadequate cardiac output. What we're going to see here is the non-cardiogenic shock, Caitlin, is going to be more commonly experienced by you than will cardiogenic shock, just simply because kids typically don't have any types of cardiac issues that come along and go in there. Some of the main causes that we would see for non-cardiogenic related shock would be hemorrhage as a result of trauma. And this is especially true if our patient has abdominal trauma, some type of a sepsis type of situation that's going on, as well as spinal cord injuries. Now, the thing to keep in mind is that when you've got a spinal cord injury, remember we talked about how flexible pediatric bones are. The spinal column itself is the same way. It's very flexible. So when you've got enough force to cause damage to the cord that is encapsulated around that spinal cord or spinal column, then you've got a patient that has had a pretty severe mechanism of injury. With hypovolemic shock, the thing that we're looking at bottom line here is that they're going to have lost fluid somewhere. There is a difference between hypovolemic shock and hemorrhagic shock in the fact that with hemorrhagic shock, we're losing blood. And with the loss of blood, we're losing the red blood cells, which carries oxygen throughout the body. With hypovolemic shock, most of the time this is going to come about as a result of some type of dehydration scenario. Either your patient has been vomiting and or they've had serious diarrhea for several days. We can see this in the patient quite frequently who has a high blood sugar, Caitlin. So you know that from going back from your lecture on diabetic emergencies, when the blood sugar goes up, the patient gets really, really thirsty and they begin craving water, craving fluids. But along with that, as a result of the hyperglycemia, they also begin to vomit a lot. So the patient can become dehydrated really, really quick. The other thing that we're looking at here as far as dehydration comes about as a result of burns. Now keep in mind that kids are at a really high risk of burns out of curiosity, out of abuse, or potentially just simply pulling something over on top of them from the stove. Burns are the second leading cause of traumatic death in the pediatric patient today. The big thing that you want to focus on when you're dealing with a pediatric patient that has a burn is that you want to provide supplemental oxygen just in case we've got some type of an airway burn that's involved, as well as IV access to replace fluid. This fluid begins to shift really, really quickly as far as moving out of the vasculature and into the interstitial tissue in a burn. So the much like we would see with patients that are in anaphylactic shock, the fluid, the vasculature is what I'm trying to say, becomes very permeable, and particularly it's plasma that begins to move out into the interstitial tissue, which can cause your patient to swell. Now that swelling can lead to all kinds of respiratory issues as well. as you're very much familiar with it, if you remember back to our lecture last semester on trauma. When you're giving a patient a bolus, Caitlin, what is the formula that you use for non-infant patients?
Is it 20 milligrams?
Yeah, you're going to give 20 milligrams or 20 milliliters per kilogram. Yeah, so on these particular patients. Now, Tariq, if you are giving fluid, okay, which would be better to give, normal saline or lactated ringers for the burn patient? Actually, for any patient that has got hypovolemic shock. Actually, the better solution is to give lactated ringers because it is a buffered solution that has some of the electrolytes in that the body is beginning to lose, and it can help to replace those. Again, if signs of shock remain after your first bolus, then we're going to give another bolus. Again, keep in mind, anytime we give a bolus to a patient, regardless of their age, listen to breath sounds before, during, and after the bolus is given. Now, if you hear breath sounds, hear wet breath sounds, in particular crackles, Hussein, that doesn't necessarily mean that we're not going to give a bolus because we got to weigh what is best for our patient against the long-term risk for that particular patient. But what you do want to do is you want to be very, very cautious about overloading the patient and putting them into heart failure. Giving this bolus, it can be repeated, and some kids may need as much as 80 to 100 milliliters per kilogram of fluid in order to replace the fluid that begins to shift out of the vasculature. All right. So again, this is looking at hypovolemic shock. Distributive shock, we see, is a marked decrease in the body's ability to have vasoconstriction. This comes about, bless you, this comes about as a result of the patient, for whatever reason, having a loss of the ability to constrict or dilate the blood vessels. When that happens, then the space itself gets much larger, and as a result, the patient's blood pressure begins to fall. Now, again, some of the most common causes of distributive shock in the patient is going to be sepsis. And with kids, in particular, young kids that are of school age, diseases such as meningitis come into play. Meningitis typically is shared very easily amongst children because they're in a school every day, they're in a confined space every day, and they have very close contact with each other. Another thing that we can begin to see here is that Caitlin, our patient, can get, some type of spinal injury that severs the nerves that are between the vasculature and the brain. So as far as the brain is concerned, everything is fine because it's getting no SOS messages coming from the body itself. From the vasculature side, it's sending messages through the baroreceptors that remain. Hey, we've got vasodilation going on here. The blood pressure is dropping. You need to send a signal out to cause vasoconstriction. But that message doesn't get to the brain because the pathway is cut. Usually it's cut somewhere within the spinal cord itself as a result of that spinal injury. When we're doing these assessments, Brandon, what do you think you would find as far as the patient's heart rate? Now, we know that normally in hypovolemic shock, heart rate's going to do what? Go up or down? It's going to go up. But what do you think would be the heart rate in a patient that has distributive shock?
Normal, or even could be Brady, but probably just normal.
Good, very, very good. You're exactly right. Especially if it's a specialized type of distributive shock known as neurogenic shock. Because as far as the brain knows, everything's okay. It's not getting any warnings to send a message to the heart, hey, you need to pick up your heart rate, okay? The other thing to keep in mind, and this is critical for you to know, is that pediatric patients can only increase their blood pressure by what? Say it again. I still didn't hear you. Heart rate. Good. Yeah. Very good. They don't have the ability to increase the contractile force, or they don't have a really good ability to bring about vasoconstriction. That is even more pronounced the younger the child that you're dealing with, okay? So when you're dealing with infants, they literally have very little to no ability to raise their blood pressure by any way but increasing the heart rate. This is one of the reasons why we see pediatric patients that compensate. Well, let me go back. For adult patients, we see compensate, then we see decompensate, 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 and then irreversible. With peds, though, we see compensate, 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 decompensate, irreversible. Because they get tired. The heart just kind of wears out. So you're exactly right, Brandon. We would normally see a normal or even a little bit slower heart rate as far as when we're looking at these patients. So let's look at some specific types of shock that we might come into contact with. Again, basically what we're seeing here is sepsis in the peds patient is going to be caused mostly by some type of respiratory illness, be it RSV or something else along that line. It is possible for sepsis to be caused by either a bacterial or a viral infection. Sepsis is quite often caused in the geriatric patient by something as simple as a urinary tract infection. Okay, that's why UTIs can be deadly for your nursing home patients. Again, meningitis is another common cause of sepsis that you might see. Now, how sepsis comes about is not completely understood as of yet, but basically something comes around that initiates body-wide inflammation. Now, Kobe, why is inflammation kind of a two-edged sword in the fact that we need it to live, but it also can cause us to die?
Well, the inflammation helps with the immune response to try to help fight the disease, so that helps to keep us live. But too much inflammation, one, if there's too much fluid, it can cause the cells to expand and rupture.
Very good.
Because it's a hypotonic solution.
Very good.
Secondly, too much inflammation, there's edema, cell breakdown, you're more likely to get secondary infections from pressure, ulcers, your skin gets worn out, your skin is your primary defense from other infection sources.
Good.
It cascades and just wears out the entirety of the body. Good.
I'm going back to my office. You can finish up the class. So, and what Kobe said is very, very accurate. Now, the thing that you want to watch, particularly, and I know this is a pediatric class, but I want to pull back in some things on older patients, is that if you've got a patient in sepsis, you want to watch their EKG very closely. Why, Caitlin?
Because if they have an electrolyte imbalance, it can cause arrhythmias.
What would be, in sepsis, what would be the most common electrolyte imbalance that you would expect to see?
Would be hypovolemia.
Not hypo, hyper. So we would see hyperkalemia. So as the cells begin to rupture, keep in mind that the contents of the cells, as long as they're surrounded by that cell membrane, is just fine. The body does well with it. When they rupture, the contents now become poisonous, and potassium now gets released into the body. Kobe.
Could that ever lead to rhabdo? There's enough cell breakdown.
Oh, yeah, absolutely. Absolutely. In burns, in crush injuries, things along that line, it can lead to rhabdo on a regular basis. Yeah, you're exactly right.
What about in the case of sepsis, though? The cell breakdown from sepsis, could that ever lead to, or would they be dead by the time you
I don't think that there would be a critical amount of muscle tissue that would break down quick enough to clog up the renal system. I think the biggest problem would come about as a result of severe vasodilation and the massive amount of potassium that's now going to come into the patient's heart.
And then DIC and all
Yep.
long before
Long before.
they got that.
Yep,
Okay.
you're exactly right. So again, when we're looking at these patients early on, what we're going to see is their arterial system is going to begin to dilate, which is going to drop our blood pressure, decreasing peripheral resistance or decreasing afterload for our particular patient. With this, we generally are going to see cardiac output as form of compensated shock now begin to increase. This is often known as the warm shock phase. Your patient is still compensating. They're doing okay. They're really, really sick, but they're doing okay. Later in the decompensated phase, now the blood pressure begins to fall because the heart is no longer able to keep that going up, and the typical signs and symptoms of shock are going to appear. In this, now this is called the cold phase of shock that you would see with your patient. I'm not going to ask you about warm and cold phases of shock, but I do want you to be able to identify compensated, decompensated, and irreversible shock in your pediatric patient. When we're looking at these patients, now also what happens is that we get really, really reduced capillary blood flow going through the capillaries. What happens to the blood? And I'll throw this out to anybody. What happens to blood when it becomes stagnant? It clots, and we get thousands and thousands of little microemboli. And remember, those emboli can join together to become a much larger thrombus that can lead to a PE either in the heart, the brain, or the lungs. The other thing that comes about in this, particularly in the capillaries that surround the alveoli, is that we have a reduction in the exchange of oxygen and carbon dioxide. As a result, our patient becomes hypercarbic, and if you've got them on their end tidal, it's going to indicate that your patient is becoming more and more acidotic. So what are you looking for in these patients? Well, these folks that have sepsis, this is more than just an infection. But if you got kids that have sepsis, they just look really, really sick. I mean, on your general impression, you can say, I'm not going to be staying here very long. Okay, so we've got to get them to a definitive care. With these kids, it's not unusual to have an altered mental status tree. When we are doing that, make sure that we are also ruling in or out the possibility of a low blood sugar. Okay? Because remember, one of the things that happens when we have an infection is saying, does our blood sugar have a tendency to go up or to go down during an infection? Nope. Actually, the opposite happens. Now, if you've got a patient that's got an infection, we would expect to see their blood sugar up a little bit. But if it's low, now we begin to think and worry about the patient potentially having hypoglycemia in addition to that. These kids are going to be hot. They're going to be burning up, okay? A little test-taking hint. When you see a patient with some type of a respiratory illness and they're running a fever, examine very closely, because most of the time the answer to whatever they're looking for, if they're looking for you to do a diagnosis, is going to be pneumonia. All right? So just kind of keep that in mind when you're looking at that. They become dehydrated because they're vomiting, excuse me, and lots of diarrhea, but especially vomiting. They can't take anything in, so they have no appetite, Caitlin, and their fluid intake drops off. So the kids can become very dehydrated really, really quickly as far as when we're going there. With them, the other thing is, keep in mind, again, cyanosis is a late sign. Most of the time, these kids will have some type of mottled or pale skin rather than being cyanotic. But if you see cyanotic, then we know that we've got a respiratory component that's going in there. A few other things that we would see in here, again, with the altered mental status, the child doesn't interact or even seem to identify who their parents are. Then down here at the bottom, our patient's going to become acidotic as a result of a lactate increase. Okay, lactate, when it goes up, converts over into lactic acid, so our patient becomes acidotic. That's bad enough, but our CO2 levels, as I said a while ago, are not going to go down as they normally would because, remember, we got those microemboli in the capillaries within the surrounding the alveoli. And as a result of that, Tariq, we're not going to have any good gas exchange. So what are we going to do for these patients? There's two things that we need to do. Okay, actually, there's three things that we need to do. One, I'm just going to remind you of here, regardless of the etiology of the cause of shock in your patient, you got to keep them warm. A patient can be febrile and begin to convert over into a dropping body temp during sepsis really, really quickly. As a matter of fact, most of the time, Caitlin, when you get the call to go and take care of them, they've transitioned over into that phase of where the body is no longer able to regulate their body temp, and their body temp begins to fall. That patient is teetering, Colby, right there on the phase of decompensated and irreversible shock. Again, keep in mind, just like adults, we don't resuscitate many kids that are over in irreversible shock. We also want to start giving them IV fluids, okay? Again, your fluid of choice should be LR more so than normal saline. LR is less acidic as far as the pH goes, not by a whole lot, but in a situation like this, we need more of the alkaline solution that we can get into the patient's body to help to offset some of that acidosis that's already coming into play there. If your patient is shocky, same thing holds true. A 20 ml per kg bolus for our patients. Reassess. If the pressure comes up, you want to watch that really, really closely because depending upon how much time you're going to have to transport your patient, because over the next hour, 2/3 of that fluid will begin to migrate out of the vasculature and into the interstitial tissue. That's why some books say it doesn't matter whether the patient's pressure comes up or not. Once you've given 20 mils per kg, you assess your patient. Regardless of what happens, you give another 20 mils, okay? I prefer for you to watch the patient and observe and reassess to see what happens. Because the last thing I want you to do, even with kids, it's possible, especially in patients that have septic shock, to put them in fluid overload and to cause them to begin to develop pulmonary edema. If a fluid bolus doesn't work, Brandon, what would be your next option to raise the blood pressure?
Pressure.
What would be the flavor of pressure you think that you would want to give?
If you carry it, Norepi.
Norepi would be a good one. Now, a lot of EMS agencies in Kentucky don't carry Norepi. I would suspect that most of the ones in northern Kentucky do. I would suspect that probably Georgetown does, and I would suspect that Jessamine County probably does as well. Okay.
So does Montgomery.
Okay, I forgot Montgomery. So these are some of your really, really high-performing EMS agencies. It doesn't mean the other ones are not doing a good job, but they want their pressors to be more of the line of, say, dopamine or epinephrine. Now, if you decide that you're going to give epi, as far as like a push dose pressure, the amount of epi that you're going to want to give is 0.01 micrograms per kilogram for your patient, as far as if you're going to administer it in a drip. You can give an epi drip. And we'll talk more about this a little bit later, but push dose epi is becoming more and more common to be seen. Once we get down in the lab in the summer, we'll actually practice drawing up epi, coming up with the right concentration of push dose epi, and being able to administer that. Kobe, what is your dosing range for dopamine for the pediatric patient?
I honestly do not remember.
I'm glad you said that because I would have been seriously impressed had you known. This is another reason why it's really important that you carry some kind of a pocket guide, because again, these are not drug dosages that we use a lot. So it's 2 to 10, okay, 2 to 10 micrograms per kilogram per minute, all right? The definitive treatment for these kids is to get them on an antibiotic, okay? The antibiotic will begin, particularly if it's a bacterial infection, but the antibiotic will begin to reverse what's happening and help the child to get better. If you got a patient, a pediatric patient that's in sepsis, is saying you need to prepare the patients and say, well, I think your son or your daughter's probably going to stay in the hospital for a little while. Chances are real high, Kaylin, that kid's going to ICU to be watched very closely, at least for the first 24 to 48 hours until they see whether an impact is going to be made by that antibiotic, okay? So our next distributive shock we're going to talk about is anaphylactic shock. Anybody have questions on septic shock, though? Okay. Yes, Tariq.
You say if you have a patient sepsis shock and he have a fever, we have to keep him warm even if he have a fever?
We do want to keep him warm because if you've ever been really sick and you've been running a fever, one of the things to keep in mind is that at that point, your patient is not hypothermic. But the sensation the patient may have would be chills, okay? And so there was a couple times over the winter that I got sick, and literally I had every blanket, it seemed like, in the house on me with an electric blanket and everything, and my temp was running like 101.2, 101.3. And so that's one of the reasons why we want to keep our patient warm. What we walk that really fine line of we don't want a patient to sweat, okay, because sweating is a cooling mechanism. So we do want the fever to come down, but if our patient is wet, and particularly if their clothes are wet, then now we run the risk of accelerating the hypothermia. Good observation. Good observation. Anaphylactic shock. This will be one of the more common types of emergencies that you will run, especially regarding foods, okay, and especially regarding some type of peanut that your patient will have come into contact with. With a lot of these patients, Caitlin, they're very, very good, even though they're kids. All their other friends are eating peanut butter and jelly sandwiches or eating peanuts, but if they come into contact with that, that could be life-threatening for them. And so they're really good about making sure that, they don't bring peanuts, they don't eat it, they know what's going to happen. Typically, they'll have one really bad experience, and that'll be enough for them. But they don't really even have to come into direct contact with it. Just the amount of peanut dust in the air can get into the patient's respiratory system and cause an anaphylactic reaction. I don't know if you've ever been on a plane, and most of the time, kids will outgrow this allergy to peanuts or to nuts, peanuts specifically, as they get older, or the reaction will become less as their immune system is not so much on hyperdrive. But I don't know if you've ever been on a plane and the flight attendant announces that they're not going to be able to hand out the little tiny packs of peanuts that have like 3 peanuts in it because there's somebody on board that has a peanut allergy. And what they don't want to have happen is the dust get into the circulation system, and now you've got somebody up in first class eating peanuts while somebody back in the very back of economy class is having an anaphylactic reaction. And so they can be really, really sensitive to that. A couple things that happens is that when we're looking at this, is the release of specific type of cells that are called mediator cells, and these come from the white blood cells, part of the immune system of the blood. When these mediator cells are released, It causes two really serious problems to begin with. Number one is it causes massive vasodilation that we talked about. And number two, the vasculature becomes very, very permeable. And now we begin to see plasma leaking out of the vasculature. As a result of that, our patient's blood pressure drops. They begin to swell. And so, especially if they're a young child and they get a lot of swelling up in the posterior pharynx, that swelling can actually cause a type of anaphylactic induced epiglottitis, where the epiglottis swells up. Now it comes over on top of the glottic opening and our patient can't breathe. It also causes laryngospasm. So that's part of that whole swelling process. When and if you have to intubate these patients, be ready to utilize a tube that is 2 to 3 times smaller than what you would normally use for this particular patient. Why? Because the glottic opening is so much smaller. Again, this was an older patient. He was probably in his 60s. This is when I worked in Georgia, who went out and he was allergic to bees. He went out and he mowed the grass, got stung by a yellow jacket, came in, started having an anaphylactic reaction. Why he didn't have an EpiPen, I don't know. But by the time I got there, all you could hear was just a little bit of squeaking noise coming from his lungs. When I visualized everything was swollen, so I tried to introduce a size 7 tube. It wasn't going anywhere. I could see it going into the glottic opening, but it was literally like taking this pen and tapping it against the table. What I finally wound up getting in him, he was an adult, of normal build and normal size. What I was finally able to get into him was a number 4 tube, And luckily that was enough. You know, I really expected this guy to arrest once we got to the hospital, went back up about 2 hours later, asked them about the patient, and they said, oh, he's back in the back eating a sandwich. And I said, no, the patient I brought in, if he survived, we're going to ICU. They said, no, that's him. And so, I mean, it wasn't this guy's time to die. So luckily everything fell into place, and we got him enough air, enough oxygen to preserve the brain function of him. Now, anaphylactic reaction can be differentiated from allergic reaction by signs and symptoms of shock. Okay? So if your patient is in shock, it is no longer an allergic reaction, but it's anaphylactic shock. Allergic reactions are usually going to be local. Okay? The other thing that you need to remember about anaphylaxis is the speed at which symptoms begin to appear have a direct correlation to the severity of the anaphylaxis. So if your patient gets stung, in a matter of minutes, they begin showing signs and symptoms, central signs and symptoms of shock, such as dizziness, increased heart rate, blood pressure dropping. They begin saying, wait, my throat really feels tight or sore. The tone of their voice begins to change. If that happens really, really quickly, Caitlin, you're in for a ride with this patient because the symptoms most often are going to be very, very severe. Here's some of the things that you're going to see with these patients in anaphylactic. Obviously, fast heart rate, fast respiratory rate. Wheezing comes about in particular because you've got that narrowed opening at the glottic opening, which just allows a little bit of air out and a little bit of air in. It can also lead to bronchoconstriction, which adds to and makes worse the air movement that's coming into play. Make sure that you know that the word urticaria is the same as hives. You will never see the word hives on a registry exam, just like you will never see the phrase gallbladder disease on a registry exam. You'll see the medical term for gallbladder disease. And so they begin to develop these, and you want to watch them really closely, especially if the urticaria is body-wide. says that the response is occurring that's coming body-wide. We will begin to see angioedema or swelling around the face. And in particular, when the lips begin to swell up like this is very, very concerning, because if you can see this much edema on the lips, guess what? What you can't see is the mucous membranes of the upper airway that also now begin to occlude. Remember, we've talked about this, that particularly for an infant, its tongue is much larger in proportion to its mouth. So it doesn't take much swelling, Caitlin, for that tongue to now occlude the entire upper airway. So what do we do for these patients? Well, first thing we've got to do is we've got to try to restore perfusion. So what we're going to do is we're going to give IM epinephrine at 1 to 1,000 concentration, as well as an antihistamine. With your dosing regimen for epi, it's going to be 0.01 milligrams per kilogram of 1 to 1,000 epi. You watch your patient, and you can repeat it if necessary in about 5 to 15 minutes. Once your patient's anaphylaxis has begun to get better, then we fall back on an antihistamine. And the most common one that is used today and has been for generations is Benadryl. We want to give Benadryl at basically 1 milligram per kilogram. And if we're going to give it IM, we want to give it deep IM. Otherwise, it hurts really, really badly. Okay? Now, the max dose that you're going to give, if you're giving Benadryl for a pediatric patient, is 25 milligrams. Okay? So we don't want to give much more than that. The reason we do that cocktail is that epinephrine is rapid acting. But if you'll remember back to some of the drug things that we talked about in ACLS and PALS, the half-life of epinephrine is about 15 minutes. So it will begin to wear off rather quickly. So what we want is we want something that's going to keep our patient alive, and then we follow in with Benadryl, which will take a little bit longer to work, Caitlin, but will last much longer because it has a greater half-life for our patient. If you got a really long transport system or transport time, such as you may have in eastern Kentucky, taking them to even a local hospital in some places over there, or if the weather is bad and you're transporting, your protocols may call for you to give a steroid. The most common steroid that's going to be given is Solumedrol. The dosing regimen on that is going to be 2 milligrams per kilogram, and we will give that up to a max of 60 milligrams. Understand that the steroid is going to take several hours before it begins to work. Steroids are quite commonly given now to prevent asthma attacks, particularly in adults. The drugs that we utilize to treat asthma attacks are the beta-2 agonists, such as albuterol. But to prevent would be inhaled steroids for our patient. All right? Any questions on anaphylactic shock? All right, move on. Neurogenic shock. Neurogenic shock is due to massive, particularly peripheral vasodilation as a result of the nervous system being interrupted, most often by some type of spinal trauma to the patient. Generally, what you would see here is that cardiac output and the volume of fluid that the patient has within the vasculature, Brandon, are perfectly fine. So we have good contractile force, and the patient's not losing blood as a result of trauma, such as what we would see in hemorrhagic shock. Our treatment for this patient is going to be a fluid bolus. Now, Hussein, remind me again, what is the formula for a pediatric fluid bolus? Very good. Very, very good. Again, if that fluid bolus doesn't work, then the other thing that we would do is we'd fall back on a pressor. Most likely on your registry exam, now again, Several of you will be working with agencies that are carrying norepi. Several of you will be doing push dose epi. The big one I want you to remember as far as for your licensing exam is dopamine, because registry will probably use that as far as your choice. And again, Kobe, what did we say the pediatric dose of dopamine was? Now I'm coming back to you.
0.5 to 10.
You're close. Double your lower dose. Quadruple your lower dose.
2 to 10.
2 to 10. 2 to 10 is what you're.
I keep on getting mixed up because I'm so used to norepi, which is 0.05 to 0.5.
Yeah.
That's where I'm getting confused.
That's okay. That's all right. That's all right. So, let's talk about some neurological emergencies. They are not really that common with the exception of seizures in your pediatric patient. Other neurological emergencies that you may come into contact with in the peds patient is going to be meningitis. Again, remember, meningitis can be either bacterial or viral as far as when you're taking care of them. Meningitis does seem to lead to more severe symptoms in the pediatric patient than it does in the adult. Now, we take meningitis serious in the adult, especially in an attempt to try to minimize the spread of it. But generally, patients will be put in isolation if they're adults when they get to the hospital. Peds will often be put into ICU and watched very, very closely. So when we're talking about seizures, basically, you understand that just from a review of your med emergencies, basically, I like to liken seizures as kind of VFib in the brain. You've got all these cells that are firing at the exact same time, Caitlin, and as a result, there's no organized electrical activity that's getting through to the body. That can lead to multiple different presentations that include the classic tonic-clonic type of movement of patient with their arms moving back and forth and them jerking and shaking, all the way up to a type of seizure known as an absence seizure. Now, Brandon, do you remember talking about absence seizures in your med emergencies class? No, it's a neurological problem, so it's not an issue as far as talk withdrawal. Absence seizures are almost found in kids under the age of 12, and basically what happens is that they zone out. They don't hear you talking. They're not aware that you're there until you either come over and touch them or you yell at them really, really loud, and then they pop back into consciousness. With these kids with absence seizures, they're kind of a pre-indicator that there's a neurologic problem going on. So the absence seizure itself is not the emergency, but parents will want to do is to follow up with these kids to make sure that there's not a more serious problem that's going on from a neurological perspective. When we are dealing with these, when the kids come back to reality, they will not remember them zoning out, okay? The down part of this is it used to be. It's not nearly as bad now as because teachers have training in this now. But a lot of these kids got blamed for daydreaming. So they would just basically zone off, stare at something on the wall or stare out the window. Teacher would yell at little Johnny, and Johnny, get your mind back over here, and Johnny wouldn't respond, and finally he or she would yell really loud, and that would bring Johnny back. So that's an absence seizure, okay? Not life-threatening, but it's something that and most of the time, teachers will identify this, share it with the parents, and the parents will follow up. Kobe.
With absent seizures, will they stop breathing always, sometimes?
Rarely. So basically what an absence seizure is actually kind of a generalized focal seizure. Now, remember, with focal seizures, you have the seizure activity in one part of the body or the other. So it could be one arm that is moving. It could be repetitive lip smacking or something like that. With absence seizures, it's involving the entire brain, but there's no any type of process of where you have a generalized movement. So that basically what it's doing is it's having a negative effect on the patient's ability to pay attention. Seizures in the pediatric patient can be either called partial or generalized. Partial seizures are when you see one part or one side of the body moving in tonic-clonic activity versus generalized seizures, which you would see the entire body moving in that tonic-clonic. With patients that are having partial motor seizures, generally, you're not going to have any loss of consciousness for that patient, okay? They may be able to talk with you, but they literally can't control what's going on. Generalized seizures, as I said, involve a sudden onset of jerking both arms and legs. This may be preceded by what is known as an aura, okay? Caitlin, do you remember what an aura is in a seizure patient?
It's like where a patient will like smell something different or like feel a certain way.
Yeah.
They know they're about to have a seizure.
Yeah, so it can be auditory, it can be visual, it can be olfactory, or just like you said, the patient can begin to feel like I had one patient that we would, again, an adult patient, because we don't run a lot of pediatric seizures, but she said she got just really, really cold just a few seconds before she would have a seizure. And that was her aura. That was a warning system that you need to stop whatever you're doing right now and lie down. Just a side trip off of here, what amazes me, I've always been a big dog person. I don't understand cats. I don't understand people who like cats. Anyway, you might like cats, but that's okay. I'm just joking. I do really like dogs, but dogs are now being trained to sense when a patient is, particularly a pediatric patient, is getting ready to have a seizure. That just amazes me, as far as they're training them with both their nose and by observing whoever it is that they're the service dog for. So it's just incredible to think that comes into play. A type of emergency that you do want to be concerned about with your patient is called status epilepticus. Status epilepticus is defined as having 2 or more seizures without an intervening conscious period. Now, hopefully you remember either from your EMT class or from your med emergencies class that when you have a seizure, if it's running a normal course, your patient will also have a postictal phase. So Hussein, when we talk about postictal phase, what is that? How does your patient act in a postictal phase of a seizure? Say it again for me, please. No, body temperature doesn't change. Tariq, can you help him out? What is the postictal phase of a seizure? Yeah, so how will they act? So it occurs, you're correct, it happens at the end of the seizure, but how will they present? What will the patient look like? What will they do? Okay. So patients that are in postictal phase will they'll be unconscious. And then as they are moving up and coming out of the seizure process, they'll begin to regain consciousness. They'll often be very, very confused. They'll ask what happened over and over and over again. Brandon, you may tell the patient, hey, you had a seizure. 30 seconds later, they're asking you again, what happened? As the patient begins to regain consciousness, now they are probably aware that they have been incontinent on themselves, and it can be very embarrassing for your patient. Do your patient a favor to show respect for them and to cover your patient with a blanket or a sheet if they've been incontinent on themselves of bowel or urine, just so that the entire world's not looking at that. That's being a patient advocate. Status epilepticus is an emergency because your patient has a seizure, they go into the postictal phase, but they never wake up, and they go back into another seizure. The danger with status epilepticus is that when a patient is having a seizure, they are not breathing, okay? So while the patient's having a seizure, you can put a non-rebreather on your patient. You don't want to restrain your patient, but most definitely after the seizure is stopped, you want to get them some high-flow oxygen to help the brain recover because it's not able to store the oxygen that is in there. The electrical impulses will damage the brain from a structural perspective as well when they are having multiple seizures. The biggest thing that you can do for these patients that are having status epilepticus, or sometimes you will hear it referred to as simply a status, is to, number one, try to ventilate your patient if you can between the seizures. And then number two, we want to break the seizure by giving them a benzo, all right? So again, a patient's having a seizure is having an altered mental status. And Caitlin, what did I say we do for all altered mental status patients? We're going to check a blood sugar, okay? So we're going to give glucose if necessary, okay? So as we're taking care of these patients, but the big thing is we want to stop the seizure, okay? And you can begin, if you're given diazepam, which is the most common benzo that we're going to carry, you can begin with 5 milligrams and give it very slow. If your protocols call for it for IV, you can give it IO as well. Let's say everything is going wrong with you that day and you don't have an IV, you're not able to get an IO started. You can give it rectally. Basically what you would do, Brandon, pull up your medicine. Please make sure you break the needle off, okay? Now you snicker, but not me. No, it's not happened to me, but I've read cases of in the excitement, they forgot to break the needle off when they're given rectal Valium. And then put on the longest IV catheter that you have, coat the outside of it with KY jelly, introduce it through the anus, and administer it. Your pickup of benzos in giving rectal will be almost as fast as if you're giving it IV. The flip side of that is, Kobe, what are we going to watch for our patients when we're giving them that?
Like giving benzos in general, or
Yep.
in a specific scenario?
In general.
Giving them too much, respiratory depression?
Yep. So we want to watch. We don't want to make them stop breathing. Okay, Caitlin.
Can't you give it benzos through an ad device,
Through a what?
like intranasal?
Yeah. You can give for pediatric patients. Most definitely, you can give it through a MAD device, and that is another option. The administration rectally is probably something you will never do in your career, just simply because now you have so many more options of getting medicine into the patient than what I had when I was in your position. But I tell you that just in case someday the world's going to end, and you got to give a benzo, and that's the only way you can give it. We talked a little bit about febrile seizures. Understand that febrile seizures come about not because of how high the patient's body temp is, but as a result of how fast the body temp goes up. Many situations you will come and the caregiver will be there most of the time. It'll be mom. And you go in, Caitlin, and you'll ask mom for a history. And basically what they'll say is my child was fine this morning. About 3 hours ago, he started acting like he was sick. He had a little bit of a temperature. And in 3 hours, his temperature has risen 3 degrees. It's gone up really, really quickly. Most of the time, the ages of these kids are between 6 months and 6 years. At about the age 6, kids begin to grow out of the possibility of having a febrile seizure. I'm not going to say you're never going to run an adult with a febrile seizure, but I will tell you I never have. Okay? Is it possible? Yes, absolutely. Is it probably going to happen? Probably not. So when you're confronted with a patient that's having a febrile seizure, assess for the past history of a cold or the flu or the sniffles or some type of a respiratory issue that has been going on with a patient over the last 24 to 48 hours. If you get there, the seizure will almost be over, okay? I've been doing EMS longer than maybe even some of your parents have been alive. In the time that I ran calls, I can count on one hand the number of febrile seizures that I actually witnessed. And many times these were septic children. And so most of the time the seizure is short acting and it'll be over. And your response is going to be, let's start gently cooling this child as far as when we're going. Make sure you assess the patient for any type of airway obstruction because it is possible. Again, this is the seizure. So your patient's going to stop breathing. The parents will often report that the patient turns cyanotic. They'll often say that their eyes rolled in the back of their head, which is not possible, but they basically have an upward gaze. And so listen for breath sounds to see if you hear any type of crackles that's going on from anything that they might have aspirated. Don't forget that the patient could have sustained a head injury that brought that seizure on as well. So kind of assess and find out from the parents, is there a possibility of a head injury that come into place here? So Caitlin, what would be some of the signs and symptoms that you would look for in, let's say, a 6-month-old whose family reported having a seizure, but who is also dehydrated?
You might have the family might report that he hadn't really, the baby hadn't ate a whole lot, or they
Good. What else? So input is down. If input is down, what else is going to be down? Output. How would we measure output? What would we ask?
How many wet diapers they've had.
Good. What else?
If they've had any vomiting or loose stools.
Good. Very good. Those are all very, very good things. Two other things to think about is as the child is crying, if you don't see tears, that's probably a good indicator that they're dehydrated, as well as particularly with infants. Assess the fontanelles. Okay, fontanelles will typically be sunken in a dehydrated child when you would think that they would be bulging if the child is crying because that's raising the pressure in the head. The care for a patient who is having a seizure, particularly a febrile seizure or any other type of seizure, is going to be the same as for an adult. We want to get a blood sugar check. We want to put them on their side. We don't want to restrain them because by doing so, we can cause additional harm to our patient, as well as but we do want to protect their head. So if there's a possibility that they're going to hit their head against furniture, against the floor, against the wall, pad that area, pad it very, very well as far as when you're going there. Watch the patient's airway, but under no circumstances do we ever put anything in a seizing patient's mouth. Never. This is a really, really good example, guys, of you heard me say that what I'm teaching you now in 5 to 7 years, a good chunk of it, if you do, is going to be malpractice. Okay? When I went through medic school and EMT school, it was routine practice that we had a bite stick that we would force in between the teeth. Why? Because we were worried about the patient biting their tongue and it becoming an airway obstruction. To give you another barbaric tool that we utilized. Now, I'm going to encourage you to Google this device, but don't Google it on the university's internet, okay? I don't want you to get in trouble. But there's literally a device that was cylindrical and had grooves around the side of it and a little handle at the top. And the medical name was called the oral screw, okay? Now, again, don't Google that or else IT will come after you because certain things may pop up. But we would put that in between the front teeth and crank it down. Did we break teeth? Yeah, we did. You do something like that, your license is going to be gone really, really quickly, all right? And so, again, don't put anything in the patient's mouth. Give them oxygen, non-rebreather if you can get it onto your patient while they're seizing safely, because we're beginning to build up some oxygen in the dead space of the trachea and the bronchi so that when the patient stops seizing, now that oxygen will be there for them to take. If the patient's having a febrile seizure, remove the clothing down to and leave the diaper in place. We don't want to too rapidly cool our patient off. Babies can't shiver. That's one of the things that they can't do, but older children can. A 6-year-old can shiver. If we're cooling our patient off so quickly, Kaylin, that they start to shiver, we're defeating our purpose because the whole purpose of shivering is to raise the body temp, all right? So cool them slowly as far as when you're going through. If your patient is in status epilepticus, get your IV started. Not normal saline, but lactated ringers is the fluid of preference, okay? Normal saline, if you don't have it, get a blood sugar done, and then you want to give lorazepam or diazepam as outlined by your protocol. What you're going to be looking at here for kids, and it's the same for both medicine, will be 2 milligrams per kilogram IV every 2 to 5 minutes until one of two things happens. Number one, the seizure stops. Or number two, you reach a maximum of 5 milligrams. Much like Kobe explained to us a while ago, when you're given a benzo, you give it slowly. So these are really small doses, Caitlin. When you pull it up, dilute it so that you have better control over how much and how fast you're giving your patient. Make sure that you're giving it slowly. I'll come right to you. If the patient has a fever and your protocols allow, you can also give acetaminophen or Tylenol at a rate of 15 milligrams per kilogram of body weight. Caitlin.
Did you say 2 or 0.2?
0.2. Did I say 2?
Yeah.
I'm sorry.
That's a
0.2.
lot.
That's a lot. Yes, that would be a lot. 0.2. Okay. Good. Thank you for catching me on that. So again, acetaminophen, 15 milligrams per kilogram for your patient. And generally that's what's going to happen when they get to the hospital anyway. They're going to give them Tylenol, children's ibuprofen, have the parents watch them and transport them and let them go back home. You can either give, if the child is old enough and they have an intact airway, we can give this as kind of like a syrup, like we would cough syrup, or it comes in suppositories, okay? So guys, I'm going to stop there. We will finish this up on Wednesday, and then we'll go over any questions you might have for the